It's 10:10. We're waiting for that Rolex time to touch 10:10. So the Rolex ad comes up, and the guy with the brightest jacket gets the mic, and he's stuck on stage. So it's that time of the year when this hall starts to buzz, because it's the time of the year when the TSF family gets together again. We come here every year because we are a part of a family. We come here every year because we want to hear what happened last year. We want an update about everything that the TSF achieved last year with all our support, your support and our support. We also come here to get a vision of what's going to happen in the coming year, what's in store for us as the years roll on, because we're getting bigger, stronger and better with everybody's support. We come here for some special occasions like the book release today. We come here to meet some special people, and most importantly it's for fellowship. We come here to meet and greet, put the faces on the names, and let the next year go ahead with fellowship together. So most of all, we'd like to thank you for taking the time out on a Sunday morning, because it's extremely hard for everyone here to take out time Sunday morning to come here and spend 3 valuable hours with us. So deep gratitude for all of you to come here, and in a way there's no reason to say thanks, because you're all a part of our family. So with that, I would open the proceedings today, and no organization is okay without a leader with a vision. And ours is our esteemed president, who's a cyclist, a marathoner, twice orthopedic patient. He's a violinist, a palmist also, and he's Dr. Raghu Verma. He's our president of the Spine Foundation, who will set the ball.
So, where we are, where we want to be is what the topic is. So, we are looking at where we are and where we want to be. When we tend to look and glow over the present and probably contemplate over the future, it's very often that you tend to miss the past. And I don't think any organization grows without just reflecting on what happened earlier. This was how we were, and you can notice that our logos changed. But this is how we started off, and all steps taken forward needed a vision and a leader. And we were pretty lucky to have a true leader. And it's vision, and we believe in that Spine Foundation that it's a single man's journey. All of us actually joined it in different stations, got in, got out, did our bit in our own capacities. And we finished 27 years standing. The guidance was probably one of the first pure spine orthopedic units in this country, in the KM Hospital, which was kind of cut-paste to a corporate hospital in 1993 with the same orthopedic spine unit. But though this transition happened, the aim was always comprehensive spine care for the unaffording patient. So the shift didn't take our principles away. Initially, it would be few steps of trying to help a patient who would be needing an intervention, and we would provide with the finances. But in 1997-98, the evolution happened, and that's the 0 milestone of our organization. From there on, because we were legitimized, we took a lot of steps forward to cover the miles. As spine surgeons, you would ask, what else can we do? I mean, provide spine healthcare services to affordable and rationalized care for the underprivileged. When we started off for the urban tour at the VN Desai in Mumbai, which is a municipal hospital where it would be done. But even then, our vision was to be pan-Indian. There are 2 tenets of our foundation which hasn't changed over the 27 years. We have a filter system, so it's nearly impossible to be there in this vast, varied country of ours. So there's a filter 1, who is generally the Anganwadi worker, or the Asha Thais, or the supervisors, or the community health workers, would be the first line of defense. Then it would go on to the primary health care and the district hospital doctors. Eventually, a local host center, which is our rural spine center, which we'll discuss in a while. And when there is a need, the filter 3, the local host, gets the Spine Foundation team, who probably visits once in 3-4 months, Mind you, with the online OPDs that happened post-COVID, it's become easier. And finally, the tertiary center, BNSI for this part of the country, and we identify some of them locally depending upon what part of the country are we offering the services. This hasn't changed. Also in our evolution, we looked at what our delivery systems are. Initially, it would be the NGOs, the entrepreneurs in philanthropy, and no else to mention but being the ones which you're going to have in Gadchiroli, where Anand is here to represent, or the trust hospitals. That's where we started our work. But we realized the big magnanimous nature of our country needed us to get access to the government teaching hospitals, the civil, non-teaching and private Good Samaritan hospitals, and the private teaching hospitals. So the delivery systems also didn't change in the last 27 years. This was June 2022, mind you, where we had the last session here in this hall. And if you look at that map, it looks pretty big, too many big names, but we were predominantly Maharashtra bound, with Gadchiroli being our flagship. A wee bit in Goa, one center in Tamil Nadu, and probably one in the hills in Dehradun. But that's where we decided that it's time to fly, but staying deep-rooted. And our aim also, and I like to use this slide of a banyan tree, which is called the Vatapariksha, where the aerial roots drop down onto the ground and actually grow from there on. So our aim was this, that we have a centralized base system, but it has to kind of stay rooted beyond us. So where we are can be classified into 5 different sections. Let's start geographically, because that's pretty impressive to look at. June 2022, I told you we were here, and in August 25, we've gone from centers in Gujarat, to Karnataka, to Tamil Nadu, to Madhya Pradesh, Chhattisgarh, Odisha, Jharkhand, West Bengal, Assam, up the hills in Himachal, up north to Jammu Kashmir, and almost there at Rajasthan and the Telugu-speaking nations of Andhra and Telangana. And if you see a grimace in one of our faces, all of us, it's actually because we made no inroads here. Uttar Pradesh and Bihar. Though we were all flying, we were still grounded because we opened a few centers in Maharashtra. We've traveled a few nautical miles across the Arabian Sea and actually in the Africa, in Burundi. So since it looks very exciting being international, let's start from there. That's 2023-24. We've had 3 to 4 camps at the Mutoy Hospital, and I have to acknowledge the Rotarian, who's more of a spine foundation fellow than all of us put together else here, who took the lead, and Abhay and Arshad, who's here, who conducted a camp. We did some pediatric spine work, and it was well appreciated. But as we came back home, we started westwards in Gujarat. Our flagship center here is the 250-bedded Srimad Rajchandra Hospital, about 225 kilometers north of Mumbai in the district of Valsad. Mr. Aspi Manochar is here and has been instrumental of having us here. We had surgical camps, and here is also where we started one of the options of involving other individuals like-minded, and there our present Bombay Orthopedic Science Society president and BSS ex-president Dr. Javeri there, who was a part of our team. We did have a few attempts at one of the centers at the Chantabai Medical College and General Hospital in Amreli, which has gone into a wee bit of limbo. We discussed about it. And we are hopeful, Dr. Manasha is here, to start our center at the Sri Wagad Welfare Society in Bachao in Kutch, Gujarat. But that doesn't end in Gujarat. We traveled east to a center which is almost at the border between Jharkhand and West Bengal, and we know the need there in Bengal, in Purulia, 150 kilometers from Ranchi. The Rotary Club, again, I have to give it to the Rotarians, Club of Purulia Services, actually initiated a program where we had OPD camps and surgical camps thereafter. He decided to travel a wee bit more east to Assam, and Vivek is here, who is and is closely associated, 300 kilometers from Guwahati, initially in the Jeevan Jyoti Institute of Medical Sciences, but the last camp at the South City Hospital. And mind you, that's Suman, I don't have to point to, but Suman, who's actually our ex-Spine Foundation fellow, who's actively involved, and you can see Dr. Mohiti and the fellows team there in the last camp which was held there. The hills have a lot of attraction for us for various reasons. And in our Uttaranchal, the initial attempts at the Nirmal Ashram in 2014, going on to the Hans Foundation in 2017, and the Himalayan Institute didn't take off as much as we expected. But that's where we got to meet Tejasvi, who is Dr. Tejasvi Agarwal, who's initiated the Swami Vivekananda Charita Hospital, Dharamwala, and I have to thank again Mr. Anuj Singhal, who's here. We'll all get introduced to each of them later, who's been instrumental to keep us going there with the hospital work, both the OPDs and the surgical camps. Staying with the hills, Himachal at Sri Lal Bahadur Shastri Government Hospital, recently in Nirchok in Mandi, where we initially had a field visit, feasibility visit, followed by a surgical camp. Decided to tread a few kilometers further north to Doda, which is in Jammu Kashmir, and with the auspices of the government hospital there and Dr. Agni Veshti, who I don't know if Agni is around here, who's a Bombay Spine Society member. He had a camp. On the left corner is Shiran, who was here for a few weeks, 4 to 6 weeks with us to get trained and look at our foundation work. The central India, and we know there's a big needy population with our experience in being in Gadchiroli, had 3 centers at Sukpur, the Anandpur Trust Hospital in Madhya Pradesh, where we had a successful camp. At the JSS in Ganyari, and a lot of us know the Swaraj area, a successful camp with a feasibility visit, and a place which is a little close to Dr. Bojraj and us, in Swasthya Swaraj in Kaniguma in the Kalahandi range in Odisha. The first time we went, we were just going to see the place. There were around 380 patients lined up there. It was enamoring that there were patients who needed urgent care, completely neglected over many years. A few of them actually had to be transferred to the All India Institute of Medical Sciences, Bhubaneswar, for further care. And we felt very, very, very weak in our legs when we saw the amount of work that needs to be done there. Tamil Nadu is a place where we, there initially, mind you, in 2022, the THI had one big issue that the hospital went for a major renovation and the new hospital is almost ready. So we should be there in this year end somewhere, restarting our whole process there. Some of you don't know Reggie and Lalita, who run the place, and it's an amazing place. It gives us the same goosebump effects like how we used to have in Gadchiroli many years ago. Just next to it, about 100 kilometers away, is Krishnagiri, where we are going to be going in the recent future, the Government Medical College in Kurubarapalli in Krishnagiri. In Karnataka, we had 2 different of the delivery systems, and just about a week ago, under the auspices of Dr. Sitarama, we started work in Sargur, Mysore district, in the Swami Vivekananda Memorial Hospital, and that was the photographs of the last week's surgical camp that we had. But Dr. Premik Nagar, who's the ex-alumni from the BM Patil Medical College and Research Center, also runs a parallel system in a private teaching hospital where we do high-end surgery as compared to what we would do in the smaller center. And that's photographs of our camp held there. But when all this was happening, we were losing ground on Maharashtra, Napoli, Maharashtra, which means where we wanted to continue our stronghold. Kankoli and Dr. Aditya, who is here, has taken the lead, and you can see Dr. Lard from the Divya Patil Kolhapur, who was involved. Also, we had a small camp at the Changemakers and Mathura Foundation for the elderly. So we can kind of fathom the fact that we have widened our horizons and gone across the length and breadth of the country, but pilferage is known, and we did have a few defunct centers as we started to grow ahead. And we believe that's generally because of lack of intent, infrastructure, and interest. So if you look at the final list, right from 2022, there's almost been, to be happy about numbers, the doubling of the centers that we've had. But we strongly believe that we will persevere, preserve, and persist with these centers. For some statistics, number of patients almost closing in on 1 lakh in the outpatients. The Indian, the rural centers almost equal. And in surgeries, which generally tends to make the ego of the surgeon go up, almost about 3,000 surgeries, with BN Desai contributing 1,500, and the rest 1,500 rural centers, and mind you, flagship program of Gadchiroli, we crossed 500 in the last year. This is one topic we are not the best at, but we want to improve, and we made some amends to improve. The more we grew, the grants came along, and our aim is to have sustainable finance. The tenets of this doesn't change. To link a donor to the center is our first aim, because we are not the best in finance. If the donor needs to be involved through us, then we try to update them with the use of funds. So recently, the global grant that came from the Rotarians, we used it for 5 surgical camps, and almost touched even in terms of finance. But we still strongly believe there are a lot of government schemes that are underused, and with such robust healthcare systems in our country, which is man-used or not used rightly, I would say we still continue to explore. But wherever there is a lacunae, we like to contribute, and we allot, document, and have reports on these. Having said that, we continue to associate the increasing number of organizations who wants avenues to provide us with their CSR commitments. So finance is steadfast. There is room for more. Sustainable economics is the aim. In a robustly varied country, government schemes have to be mandatory. But what's the most important point in this section is we are looking at cost effectiveness. The effort made by the foundation, all the local centers, we need to justify the cost. And this is one of the bases of our research work that we are looking at in the future. Donor to center link is our ultimate aim. Methodology and personnel. So there are some principles which never change. We believe in decentralizing for more access. So we want to define modules which strengthen the filter one. And in every feasibility visit that we travel, much before we meet the local center heads, we believe in meeting the foot soldiers, which is the health workers. And we are looking at, with search in Gadchiroli, training modules for the same. Intervene, but be conservative. And this has been our ethos. If there is something that can be treated conservatively, do that. It's only intervention, and that 80-20 rule exists. 80% don't need an intervention, 20% need some form of intervention. The local facilities, are they good enough to provide, or do we need to refer? Is a decision we take in liaison with the local point person. Because I remember an offhand, and I don't know if Dr. Bojaj remembers, a small team meeting, me, himself, and Dr. Veera Joshi had it probably in 2008, and I remember Veera Joshi saying that the mind of complications, because the word spreads quickly. And that's been our ethos. If there is adverse reactions are known in spine surgery, but you don't let it to go into complications. And this is something, even in the recent past, if there was a problem, till the problem gets sorted, we don't buckle. It was very easy to operate and go away and leave it for something. That does happen in camps. Our principle is very clear. Connect to disconnect. Now, half of this hall is the point persons, as we name them. They are local, they are on the ground, they are oriented, they are organized, and they have an interest. This can't be overemphasized. I don't want to take names because the names will be taken later, but for us, every one of you who are the point persons in each center matter. They are the wheels of our organization, and that's very important. It strengthens the department, make them self-sufficient, and ultimately they need to take over what we've been telling them to take over with. That's our ultimate aim. The online OPDs, which was actually a default system which came up during COVID, has really made a big difference. Because sitting here, we can at least make some judgment of what care needs to be given to an individual patient. But there is one group of private teaching hospitals, because they are already doing what we are doing. So this offering the services of the same doesn't in any way add up. And recent past, because of ever increasing newer techniques of surgery, not to name a few, the endoscopies and otherwise, a few of us in the Spine Foundation were trained and pretty good at it, started to impart knowledge into those centers, adding up to our repertoire of services. you have to sensitize the next gen. And I think this is another part which is part of our fellowship program, where every next generation needs to be in the same boat with us. And this is a big step that our organization has taken, especially with the leadership of our Dr. Koshraj, where he believes that the future lies in the group of the next generation of doctors. So this is one of the meetings that he conducted for the medical students in JJ Hospital and Medical College, where we try to bring in them into the fold, instilling the idea of seeking to help a larger part of the community, and it has to start early in their lives. But there were some fellows and some volunteers who had no option. And, this is a list of all of us here, hiding somewhere in this hall, in case you're not here. And it's time to give ourselves sometimes a little pat in the back. So all of us stood by our leader, and no questions asked, and we are on the job. But is the Spine Foundation ending here? No. I don't think a surgical camp can be held without having these three people here. And I think I have to mention Roshan, Sushant, and Maske. They are the pillars, and I know how it works because 4 OTs functioning continuously, all of us are engrossed in what we need to do in surgery. Nobody is even bothered about whether the implants are getting autoclaved right. These guys work continuously, incessantly. So a big thank you. The stage and the setup here actually has happened because of some coordinators and managers. I've put some names, and this is not the ideal designations we have. And our team with Smita, Gargi, Mahesh, and Avdut, a big thank you. Our CSR commitments and research coordinator has just joined Bhargavi. She's a little enamored by what's happening in our, but she's getting into the system, and a big welcome to her and people. Interestingly, there is one number that's called generally for the Spine Foundation Fellow, and it's like you just hear her voice. A lot of our fellows have not even actually seen it. And yesterday when we had the meeting, everybody recognized, oh, this is the voice we hear. And Anita, who's somewhere here sitting, and a big thank you for her. Because she's been at it, Fatima and Pooja. But as surgeons, we look around 3 departments. And these are actually the faceless group. They are masked up in the OT, so they don't even know who is this. In the physiotherapy department, though Gaurash leads our physiotherapy department, but there are so many of them who are actually doing the work. And the radiologist sitting in a small room and reporting. Department of Anesthesia, Rehabilitation, and Radiology, only way to thank them is. But all this doesn't happen unless you, the Good Samaritans, the providers, and the beneficiaries, them. If they are not there, where are we? And I don't think we even exist without them. But for the entire humongous work that happens, there has to be a person who ceaselessly keeps working, continuously keeps introspecting, always looks at everything being right from the food that was served in the meeting yesterday and within the meeting. Looking forward always without losing the step that lies back. I think we have to thank you. As clinician, research generally tends to be not our forte. We tried a wee bit. So in 2010, we had the first Gadchiroli camp, which assessed the possibility of need of spine care in a rural setup. And that was a few of us much younger there in that photograph there. But in 21, we actually got to get this published. And Anand Bang here, Anand, I think, a big thank you that we had an editorial of 7 articles which came up in the Journal of Repute where we presented it. But it's nice to be running on our laurels, but there is some research introspection time. And we have 2 aims very clear here. Are we doing any justice to our patients? Especially, is this cost effective? Is there a lack of efficiency of what we do in a corporate hospital in Mumbai as compared to what we do in a rural setup? Or is this sustainable? Is this something that can be done by somebody else? And we believe that it's better to know now than ever. We cut the bias because all research generally happens by the same unit and they always have a bias. We got an independent group of people to look, and Denny here is actually taken the lead to do it. We had initially 2 MPH fellows who came in, and we are looking at all those pointers that we looked at. Even to look at, does our Gadchiroli model reproduce itself in other parts of the centers, or is there a role for AI? We are honestly behind schedule here, but we'll get there for sure. We are a shy organization, but we've changed leaps and bounds. People know us now. And the initial steps actually happened with the brand book company, with Joy and Mamta, who actually started the newsletters, the handouts, the arts exhibitions, the events, and for that matter, the Gadchiroli Chronicles actually come from their repertoire.
Just a little note that applause is welcome but not mandatory. It's just us, alright? So just be informal and easy. You'll wonder what I'm doing, right? I'm trying to Google why I'm getting neck pain. So you know that the lifetime incidence of back pain in the world is 84%, back and neck pain. Now, unfortunately for the spine surgeon, only less than 1% of them actually need a spine surgeon. But 100% of them actually need a physical therapist. The physical therapist is the person who creates the magic. He enhances our results. He makes what we do look better. And we have one rock star physiotherapist with us. All of you all know him, Dr. Gaurish Kekre, who's going to be up next. He has seen ups and downs in lives. He calls them squats. He says, Gaurish says, don't say you can't because you'll do it anyway. Don't keep count. I'm going to get back to 0 again. Don't say you want to go home. I'm going to keep you back longer. And don't say it's impossible. I'm going to make it possible for you. Ladies and gentlemen, our star physio, Dr. Gaurish Kekre.
Good morning, everyone. So happy to have everyone here, and really a big thank you to the Spine Foundation for giving me this opportunity to be part of the rehabilitation model for the Spine Foundation. So I'm going to actually talk about rural realities, trying to offer urban solution to the rural realities. What happens when we go into the rural areas? So at Gadchiroli, we have tried to basically open up a rehab model where we have done a lot of trials, lot of pilots. They are still in process, but we are been trying hard to kind of convince the patients, work out with the stakeholders, all those things. So let's go through the presentation. So idea about rehab came in because everybody here is a spine surgeon, and why rehab? So when we did the prevalence, there is a big prevalence of musculoskeletal and spinal disorders all over India, mainly prevalent in rural areas. So we did a bit of prevalence study. One of the main studies was done in Gadchiroli only. So in rural India, there are so many rural areas where musculoskeletal and lower back problems are common. Rural Maharashtra falls into the medium category of this. Among the musculoskeletal disorders, low back pain and cervical or neck pain falls among the most major part of this problem. When you go to these rural areas, most of these are farmers who do a lot of strenuous activities, no proper ergonomics. So these people basically try and face problems, and they don't have skilled therapists or skilled doctors to kind of go to, because there are multiple reasons for it. So if you see urban versus rural, here we have patients taking our appointments, waiting for 10 days or 15 days for our appointments. But when we go to the rural areas, we end up not receiving, or they are not that welcoming for the doctors because they have their work, and work is their priority. So we actually have to reach out to them, go to them, convince them that they have problems. So basically in Gadchiroli, we found these things. What were the challenges in the villages? So when we started going for the camps, we found that a lot of non-specific people started coming to the camps, not specific to spine problems. So everybody starts coming for the camp when a doctor is coming from Mumbai or anybody. So they just listen doctor coming, and they start coming for the camps. Again, when we ask them to come to the centers, these are all daily wage workers. They end up losing that day's income, and they will not come to you unless they have absolute disability or a big problem. So reaching out to them was important. There is a very limited access to skilled professionals in these rural villages. So again, training the local crowd was important. Early signs identification is important, because what happens is, if these patients are not coming to the doctors early, they come to them when they are disabled. Till the time they come to the doctors, they are already in a bad shape, and the outcomes provided are not as good as what we can do at early stages. So ending up into disability is something which leads to all these problems. So the idea of coming up with a model of rehab was reaching out to them, improve the access and coverage, reaching out to the community. As we know, Dr. Raghu sir spoke about 80% cases actually can be treated conservatively. Preventing these conditions from getting chronic, improve access to rehabilitation services, early detection of red flags was the idea, reduce burden on delayed presentation, specialized opinion by reaching out to the doorsteps. Again, when we kind of screen these patients, we can actually cut down the time of the specialist who really comes from Bombay and then reach out to them. Pain relief, again, in the community is important. Highlighting the prevalence of these problems was important. So what we did was we did a pilot in Gadchiroli in a village called Gadchiroli, from where our learnings actually started evolving. So we did a research where these patients mostly seek treatment from community health workers, which we had found. So we actually made a team from Mumbai. We coordinated with team from Gadchiroli. The first phase was to make a team which coordinates with the team in Gadchiroli, reach out to them, talk to the health workers. Health workers went to each and every house to find out what problems they had. So we marked 4 or 5 problems: neck pain, back pain, knee pain, shoulder pain, hip and ankle. These were the 5 main prevalent problems which we found out. We created awareness campaigns in the villages. So in Gadchiroli, actually we and our team made announcements in the car on the previous day that we are going to make or hold camp like this. We actually posted posters, campaign posters in the villages, in every shop. We met the sarpanch and told that we are going to conduct such camp. Even tried to convince the sarpanch for getting patients for us. He had a shop of ice cream. So every day after our camp, we used to go and eat ice cream in his shop just to convince him that you have to counsel patients and send it to us. Then we executed a camp where we basically hired a school, a public health school which was there in the area. In the camp, whatever was conducted over the 7 days, every day evening we were documenting. So we took a baseline disability measure where what problems they have when we started treating them, and at the end of 7 days, what problems are still persisting, are they better, not better, all those were documented. Dr. Anand Bang was actually behind us to kind of document each and every step in the camp. This was the inception where we went in a bus, a team of 5 doctors from Mumbai as well as around 7 doctors from Gadchiroli were part of it. Multiple things. We had actually carried a complete robotic equipment also from Mumbai for taking some outcome measures. So it was a very good the response from the crowd was amazing. We actually identified, so in that camp we came to know that there is a lot of problem, lot of disability, and we need to basically reach out to the community. That was important, where Dr. Raghu spoke about the model, which we actually started doing that after the camp. So the model, actually we tried to revise the model where community health workers could become the first filter of the system. Then a mobile physiotherapy unit which goes to the community would work as the second filter. A center, physiotherapy or rehab center in the at Gadchiroli, the local center would work as the third filter. Then the doctor locally there, who is a physician or an orthopedic, can work as the fourth filter, and the fifth filter would be from Mumbai, the team of doctors from Mumbai. So this was the filter system. What we tried to, we are still trying to kind of make it more tight and try to work out with this filter system. So we tried creating red flag identification and some basic treatment strategies so the community health workers can actually address the patients in the villages themselves. So they actually run their small clinics in the villages. So we have trained them for identifying red flags. So if they get some red flag, they have to immediately refer it to the center. If there is no red flag, then they can actually, we have trained them and they can actually offer some basic care in the community itself. This is a village health worker who has a kit of her own, who has some equipments where we have trained her with those equipment handling, and she basically runs a small clinic in her community. So these are still under trial and we are still kind of refining. There are multiple pilots going on. We started in 2020. Still the pilots are running, so you can imagine how much we have to refine. Every time we go, there is some new outcomes which we look at, new learnings what we look at, and we are trying to refine it at each part. These are some, I think, videos from the community camps. So I'll just show you one video of a patient who came with a complete bent back. He came every day for 7 days in the camp, and this was the last day when he actually walked. So that was something very positive for us. He took nice pictures with us, so it was very good and very satisfying for us to kind of be part of that journey. So again, when we go to Gadchiroli, we basically have a local center which was initially 300 square feet center which we started, and now the center there is around 4,500 square feet with a good aqua pool inside. So this is how we have grown over last 10 years in Gadchiroli center. We have Dr. Datta who really helps us with the local team. If they are having difficulty in identifying the red flags, then Dr. Datta actually helps them to basically screen and then either refer to the Mumbai team or again address it there itself. So we actually did a video conferencing training of the community health workers during COVID phase. So we did a lot of training. The local team was there. Dr. Bojraj sir and I, as well as our rehabilitation team, did some training from here. We took their exit exams. We did a lot of refining, and these community people actually went into the community and started treating the patients. This is again every Friday we have a video OPD of patients who the local physiotherapy team feels that there is a problem and they are not able to address, then they connect with us. Our rehabilitation team here, Dr. Fleur, Dr. Lakshita, all these people actually help us to do a video consultation every Friday. We do it from Mumbai. This is the present department of Gadchiroli. So we have a neurological department where we admit patients. There are 5 beds, and this is a recent aqua therapy center which was inaugurated by Bojraj sir in this the current month when we went. August when we met. Another proposed model is a PTA training model. It's like a physiotherapy assistant, because getting skilled physiotherapists in these rural areas is difficult. Again, when you get a therapist and they leave and go, running that model gets difficult. So having the local team trained is a very important model, which we are working at. So we are trying for local people who are motivated. We basically would do skill training for them, but the main criteria is their motivation to work with us. Idea and vision here is to make the resource available locally, utilizing the local population, targeting disability, promoting inclusivity in all communities, and if possible, building up an entrepreneur model for the local population where they can run their own clinics and maybe become an entrepreneur. Again, key takeaways are urban rehab models are not replicable in rural areas. There are a lot of modifications what you need to do. Filter system, if we work on it, would be a very good idea, because then the patients will reach early to the specialist and we can basically work on their good outcomes. Prevention, early detection and tailored solutions is the vision. Again, what I learned in public health is if you try and apply higher skills, this is not replicable. So try and be basic. Things which are replicable should be practiced in public health. Dr. Anand has actually taught us this over the years. The motivation, Sir and Abhay Bang and Dr. Abhay Bang and Dr. Gani Bang are always. One more very important motivation all the fellows actually know is our Shahi Tukda, what we always eat, and the journey itself is very important. So from here we look forward to the Gadchiroli journey every time. Evenings we go for our night walks. These are things which are very important to motivate us to keep coming there. Finally, I invite each one of you to join us in this journey, experience the change. Thank you.
Thank you, Gaurish. Always understated, always behind the scenes, but he's a mover and shaker. As you can see, he makes our work look better. So there is research is what I'm doing where I don't know what I'm doing. And then there's lies, there's damn lies, and then there's statistics. These are all these untrue quotes about research. Okay? Our president told us that if you are doing something good, you should have verifiable outcomes. And that can only come out of research. And public health research is one big demon. It's an elephant in the room. No one wants to touch it. But we have one rock star, Dr. Benny John. He is on the advisory board of the TSF. We are very, very lucky to have a guy of his brilliance. He's a master's in public health, and he lends us a hand and a leg and a full body to help us conduct public health research, help us bring out the work that we do. It's a challenging job, and we're going to hear it from the master himself. Over to you, Jenny.
Yeah, thanks. Good morning to everybody. So it's a bit of reflection, but also the challenges where we all started. I thought in the morning I was preparing, there's no action, no research without action, and no action without research. I think the social psychologist got very interested. Where it all began is, I was actually meeting Dr. Bojra in a common place called Center for Study of Social Change. Way back in 2007, we thought together. So what we did was we both took a kind of a bus. We went to places like Dharwad and Gadag. At that time there was this unique business model which was typically the surgical or any of those specialized was available in a tertiary care hospital. And at that time I think Dr. Bojra was also looking at VNJSI as a potential. So we were trying to see whether a secondary care hospital could also become kind of so we had a recce. We went, I think, probably it was continuous from Bombay to Belgaum, from there to Gadag. Looked at this model called the Vatsalya hospitals. I think Dr. Sitaram might know from Karnataka. This is now a case study which developed in 2004 by two medical doctors and they used the social entrepreneurship model. So it looked at financial sustainability, it looked at I think it was tier 2 cities, so it was not basically in Bangalore or in major cities, it was in these cities. So the idea was to understand how these models operate, function, financially sustainable, and that learning, both of us, with only 2 people, so we had dosas, idlis, but we were just in the bus, we didn't book any car, we figured out our own way to understand those things, and then we came back and said, okay, let's see what we can do. The other thing that we also wanted to do was to understand what are the problems or the health problems, because CSSC is based in the H East Ward. Dr. Siraj is there, who's worked extensively in that area for many years. What we trained is, let's go into the slums areas, find out, and I think one day Dr. Gujarat said, let's find out if injury happens, how are they able to come out? And we actually went to these narrow lanes, which has now become famous because of Slumdog Millionaire and Gully Boy and all of those movies, but we went and we started walking from Bandra Kurkula complex. By the time we reached, if Dr. Gujarat remembers, I think it was the wall near the Santa Cruz airport. So we went that deep inside, houses which are built on large pipes. Cost of water to a household might cost, because these are all illegal, so 1,000 rupees a month, unimaginable even in our kind of settings. And that opened our eyes that whatever we have to do, we have to ensure that it reaches the community and it is accessible. I think just producing boardroom-based solutions but not reaching the community, at least we can have. So these were the first learnings that both of us had. Of course, I had my independent learning, he had his own. And we came back, Dr. Poddar was also our sounding board. Is he there, sir? Good afternoon. So he was our sounding board. Every Wednesdays is when all the 3 of us could meet at that place, and we used to discuss and figure out and take advice from his experience. And that is when we thought that can we put some first level outcomes in place. We started initially with PN Hospital and simple Excel based systems where we said, can we start measuring clinical outcomes using very simple measures, either pre-operatively or post-operatively. And we use scores like visual analog scale, we toyed with Rowland-Morris questionnaire, and then we slowly moved into what is now called the Modified Office Disability Index. I think Dr. Raghu in his presentation mentioned, so somewhere since the data was getting collated, Dr. Gujarat said, we are now getting a lot of outcomes data, can we look at an outcome assessment? Luckily I had a master's student who was from a physiotherapy background, and we said let's embark on collecting all the data from 2009 to 2021 across both the centers, which was traditionally Rindesa urban poor, but also the rural surgical camps. But we felt, and we both, Dr. Gujarat, we discussed, can we show that our outcomes are comparable to even a private hospital such as Lilavati, and we picked up that as our comparator. So we said let's take the highest standard that is possible and said these are outcomes comparable across these centers. So we embarked on a study looking at, luckily she was interning under me, so I had some control and discipline and supervision. So we collated this data for probably, I think, 1,000 and odd patients, and we are now finished the analysis and aiming to write up the manuscript. I mean, we already completed, but we had some round of discussions. I think one of the things that we also value is quality, because we're looking at a lot of outcome-based data. So that is where the first attempt started. I'm not referring to a lot of the Gadchiroli thing because I'm little connected to the outcomes one. But the challenges that we had over a period is, I think we still use a paper-based medical records. Doctors are busy with their surgery, they come out, and then there's a huge gap of time. And what they tend to do is move into an Excel-based collection systems. Imagine multiple centers with each individual Excel sheets. In fact, one of the few ones we just spent time was collating those Excel sheets and making sense out of it, at which center, which outcome, which patient, all of that. So these are some of the challenges, and then also the challenges about outcomes, because we are those who are aware of, we were looking at a specific condition, lumbar stenosis, and we looked at decompression and other procedures. We felt that if the outcomes have to be there, patients are in rural areas, they're not going to come back, let's say 12 months down the line. So can we look at telephonic Should we look at a 3 months, 6 months? Should we ask them to come? So these are some of the current challenges, and we just had a discussion, long discussion yesterday, to figure out how do we streamline this so that our outcomes assessment becomes part of our daily care. So some of the ongoing initiatives that we are currently doing, I think, we can't keep out AI these days in anything that we looked at. I think we tried a small bit on using voice generative AI, which is basically to try to check if based on some commands of responses, can people be understood that they have some kind of a back pain or any of those. That's one. The second is I have Dr. Vivek Verma, I don't know, I don't see him. So he's my collaborator, yeah, he's there. So we have a big project funded by the Indian Council of Social Sciences Research. It's a 5-year project. And it's around, I think we are working in 4 states in Northeast, Assam, Nagaland, Arunachal Pradesh and Mizoram, right?
Tripura and Meghalaya.
Tripura and Meghalaya. So this is a multi-morbidity study. This is the first study in the country where we are actually having a cohort study for 5 years. So because of the TSF engagement, we have included spinal disorders as well into that study, because the same model exists for all other disorders. We are looking at diabetes, hypertension, cardiovascular diseases, a little bit of mental health, but because the TSF areas is there. So this is the second thing. We just finished collecting data about spinal disorders in the Northeast. And I think just to add to Raghu's point, last year we entered Northeast, I think in Silchar. Dr. Vivek is a lead there, which is working within the medical university setup. So this is what currently we are focusing on. Of course, there are other initiatives like trying to document a bit of what Dr. Raghu already mentioned about the implementation model, the 5-filter thing that Dr. Gaurish has mentioned. So these are some of the other documentations that we want to do. However, we're not trying to foresee what the future is. We are trying to see how we can enable it. And what we are looking at is, can we develop dashboards where people can just use the Excel and the outcomes can be easily visible. We just discussed an idea yesterday on principle. Dr. Bujaj says go ahead. So we're going to start thinking that how can these clinical outcomes, it won't be a real time, but you don't need to redo the analysis because we've already done the large legwork on 1,000 and odd patients. So that way we can just use additional data as it gets entered. You can have more dashboards and some visualization would be possible. So almost on some gap basis, depending on how the data is entered, all the outcomes assessment can just be visualized on a small bit. There is some discussion that I'm trying to figure out. We, along with a friend of mine who's an epidemiologist and a technology guy in Trivandrum, we developed what is called as a small language model. Some people might be familiar that ChatGPT is a large language model. Small language models are basically very specific to a disease. So if I just type, and this is useful for health workers if they want to have understanding of, let's say, because they can't remember all the training, Dr. Gaurish mentioned, and I think Raghu also mentioned, they can't remember all that. So if they have a small tool where they can just put questions wherever they have a doubt and they can answer, that model is called a small language model. We just initiated a little bit on breast cancer, and it can also derive data from medical records. So that is another format of what it is. So I've just sent the details to Dr. Bojal. We are seeing whether that is something that can be integrated into the company assessment where health workers and data can be collected. The other thing is also to identify whether we can actually look at risk prediction models, let's say pre and post using scores or any kind of MRI. We're just discussing that. We haven't kind of figured out what would be the actual methodology. And I think risk prediction models are becoming important now because of regression and other tools that are available, including machine learning. However, this requires some data set. We just had an initial discussion yesterday and probably will try to see how best we take that. And finally, one of the important things I think Dr. Ravi has already mentioned, I think we want to do a look at social return on investment. I think some of you are already donors here, and the value is if 1 rupee comes from a donor, is the TSF able to give more than 1 rupee, that means the donor gets positive returns for the investment, and that's the calculation. So we have put up a small approach that we are putting it. I think Dr. Bhargavi has already been mentioned. Probably she might reach out to some of the donors and patients and for the fellows as well. But we have to figure out a method on how do we calculate the so-called social returns. For example, if somebody's been working only for 2 days but with back pain or low back pain, and then he gets surgery from TSF and now is able to work for 5 days, so the additional income of the right 3 days will get converted into the social return. So that's a very simplified version, but we would like to do a much sophisticated version to look at the cost and the benefit, but also the social impact, a combination of both, so that we can show true value of money. I think I'll end there. Thank you all for your time.
Denny, because I think none of us even understand some of the words that you use, and if it was not for you, we would not be able to put ourselves out there. So thank you for being with us on the TSF, and we look forward to you spending more and more time for us. Thank you. Now they say that what happens in Vegas goes on Instagram. So the TSF has been a shy organization, as you heard, and suddenly now we are out there, and that's because of this one lady and her organization, and we're talking of none less than Miss Archana Bhojraj, who is started this company called Pet Media, and that has significantly put us out there. They say when you're looking at Google and you look at the second page, you must be really desperate to look for the answer. And she puts us on the first page of Google. So this is an entirely new facet to the Spine Foundation. You've not heard about this before, but it's happening for the last 1 year. And Mrs. Bhojraj and her team have been doing a great job. So Archana, it's over to you to tell us how Pet Media handles our social media.
Good morning to everyone. So I'm Archana. I'm the Chief Executive of Pet Media, as you know, the official media partner of the Spine Foundation. So at Pet Media, we believe every story has a power to change lives when it's told to the right audience. And the nation, over 500 million active social media users, the digital platform is no longer just about the connection, it's more about the transformation. At Pet Media, we believe the numbers only matters when they make impact. India has more than 500 million active social media users. For the Spine Foundation, this number is not just statics. It's the bridge, a bridge that connects the specialized spine care with the communities that need it most. Social media, which we look forward in this PPT. So, how we are changing the landscape for the NGO. Here we means the social media. So social media has transformed the way of NGO because it's connect to the world, not with only the locals. With the help of social media, we can connect with the world with a shift from local impact to the global visibility. Donors, volunteers, patients now discover NGOs with the help of Instagram, YouTube, Facebook, online first basically. For the healthcare NGO, digital presence makes them to get more trust and reaching, because now everyone, when they heard about any NGOs or any kind of thing, they go to the social media, they reach out, look out the things, if they are, whatever they are saying, it is correct or no. So the digital shift for an NGO is like, here's some statistics there, 4.9 billion social media users worldwide. NGOs cannot ignore this medium because with the help of social media, the reach of the NGO or any other organization can be, make more impact. The social media is a storytelling skill. It's a real-time transparency and the donor engagement. 94% of successful NGO use at least 2-3 social media platforms actively. For example, the Instagram, Facebook, maybe LinkedIn, sometimes Twitter or YouTube. So why social media matters for the NGOs? Because it creates awareness, which is very much important for any kind of organization. It creates the credibility, it helps for fundraising, it involves the engagement, and it makes accessibility easier. So the global key static for the social media is like 5% people who engage with, social media. Now, being offline engaged with with the NGO is difficult as compared to the connecting through online presence, because if you found a website of an organization, it will be easier for you to donate or to involve or to volunteer with that thing. So 1 in 4 volunteer now discover NGO through digital platform first, not offline outreach. Because today generation is Gen Z. They won't go to the village just to search of an NGO, but they want to do good, because Gen Z doesn't mean they don't want to do good for the society. They also want to return back to the society. For them, digital presence is very important for any NGOs. Video content, which drives 12x more engagement than static post for the NGOs, because digital video post always, it's always sum up of the emotions, the music, the storytelling that can't be created through only static posts. So video engagement is very important. Now the challenges faced by the NGOs without digital presence. So the limited visibility impacts. First of all, they stay local only, because if you don't have any social media, any digital media platform, you can't reach out the bigger population. Maybe you can't cross your boundaries. Word of mouth is good enough, but word of mouth won't go beyond as much as digital marketing can go. Donors fatigue due to the lack of communication. With the help of a digital marketing, any donor can communicate real time with the correct person. Patients, peripheries, unaware of available program. With the help of these, we always keep posting what program is going to happen, what camps is going to happen at what place, that sort of thing. Struggle to attract young generation, which I talk about the Gen Z. If you want them to connect with you, you need a social media presence. So the mission of the Spine Foundation, bridging advanced spine care to undeserved under-rural communities. Their achievement is 27 years old NGO with 12,000 plus OPD camps and 300 plus successful surgeries, plus 1,000 plus volunteers. But the challenges were great offline impact, but limited online awareness until 2024, which was 3 actually, I'm so sorry. Digital journey with PEP Media to TSF. We created the awareness with the help of posts, videos, doctors interview. We shooted all the camps, what they are doing. We did the trust building by the help of patient journey. We take interview of the patient to, just to convey the message. How was the patient before surgery? How his or her life got changed after the surgery? The community building, online campaign, interaction. There are many more. Then the content implemented. When we implemented the content with the help of education reels, patient story, case study, creates impact. The number that speaks. Now we have, for only the TSF, the estimated reach of Instagram is 2.5 million in just 2 years. In a Facebook, we have estimated reach 298.6 thousand. In the YouTube, we have estimated impression of 580K. So the impact of social media on the Spine Foundation, we created the awareness outcomes. We reached extended beyond rural camps to thousands across India. Spine health education become accessible online, because now if you have some back pain problem, you can, in any person in a rural area, he can easily get the information with the help of YouTube, because we have posted so many posts related to spine care on the YouTube shorts, YouTube videos, and most of the rural person or villagers, they know how to use YouTube. Then the myths and misconception reduced through bite-sized content. We created this trust and credibility. Patient story, basically what they do, patient story humanize the NGO's work. What they actually do, we can portray the same thing with the help of patient story. The doctor's podcast, reels, all helps to increase their devotion, their dedication to the work in the NGO. Because serving each weekend to an NGO for a doctor who has their practice in the metro city. They also got the opportunity cost. They actually lost some patient over metro city to help the rural person, which we shows with the help of doctor's interview and all. The real world impact. More patient attended scam after social media posts because we got so many, requests or inquiries from the patient side. Like they were asking if the camp is going to happen, Vijapur, can I come? Can I show my, some relative or myself or my parents, something like that. Volunteers directly connected with us via Instagram and LinkedIn. Some of the physiotherapists connected us, some of the just Gen Z type of person connected us because they were asking, can we participate some activity of the TSF? Across India, healthcare profession began volunteer after coming across TSF online. So what is digital awareness? Your digital presence creates the visibility, means the local impact becomes the global awareness. The stories of the NGO become the power of the NGO because people connected with the faces, not only with the numbers. Because as a human, you can connect with the emotion, not with only the aesthetics. Consistency, the consistency of the post and the videos create the trust. That means, okay, this NGO is actually working. So regular update builds reliability. Then the transparency, how much donation we are getting. The transparency is very important for any NGO. Showing impact basically attracts supports. So the road ahead, regional campaign for the deeper rural connect. The YouTube documentaries, which we are planning to do more and more on the patient journey, building trustworthy online communities. There are some statistics which I have presented here. So I can explain this. This is the Instagram analytics from Jan to March, where we have the total reach. You can see the total reach is 1,65,897 only in the 4 months. The total followers which we have gained is 3,172. The total viewers is 1,38,539. And the basic thing which works for the Instagram is like, comments and share. We all know about that because we all have the Instagram account, right? For the NGO to getting likes like 490, it's good enough. The comments is 43. These are the only comments, new comments. It's not the repetitive comments. And the shares is more than 145 in 4 months. The next 4 months, which is May to August, our total reach has increased from 1 to 5 lakhs. Our followers increased to 7260. I'm sorry, there's 10 is not there. And the total view has increased from 1 lakhs to 6 lakhs. The total visit in our Instagram account is 8,123. The likes has increased from 492 to 3,560. Total comments has increased from 43 to 120. And the total share has increased from 144 to 260. Same applies to the Facebook. We have some analytics. The total reach from 7,000 followers, total views more than 1 lakh, and the total visit is 1,974. Total reach in this month was 14,700. Total views is 6 lakhs, which is a good number, and total visit in the profile of Facebook is 2,500. Now talk about the YouTube, because YouTube is very much accessible in the rural, urban areas. People used to devote their time on YouTube. So the total impression only the Spine Foundation videos is more than 4 lakhs in just in month of Jan to April. To more than 30% have subscribed the channel. How many of you during the last month have subscribed any YouTube channel? Any of you have subscribed any YouTube channel during last month? Not really. So it's really a difficult job to compel or to make people aware or to force them or to ask them, okay, subscribe our YouTube channel. So 30 people subscribe YouTube channel. Total views in YouTube is more than 4,000. Likes, comments is not necessary to mention. Total impression which has increased in last 4 months is 32,000. Total views is 5,345. So this is it. But So basically I was talking about this, so the social media. We can understand the importance of social media. It's just become the strategic tool for digital awareness. Through these platforms, we are able to educate people more about the specialized spine care, importance of preventive health, and the showcasing initiative that reach beyond the urban center. Every post, every videos, every patient story shared online, it's more than the fill a feed. It sparks awareness. Awareness that leads to action. It builds trust. It connects those who are searching for hope with those who can provide it. So when we speak of the impact of social media, we're really speaking of digital awareness as a lifeline, bridging gap between the advanced spine care and the millions of people across the nation who need it most. And that is a transformation Web Media is proud to have. Thank you so much.
Like, share, subscribe. But looking at the crowd here, I'm going to say please download Instagram first. But thank you for getting us there, because if you're happy and you know it, please show it. And thank you for showing us to the world. And it's been a huge change for our presence in the social media. It's created a huge change and a buzz in the community, and that's helped us in a very, very positive way. Thank you so Web Media for doing this. Now history, if you go by the Gavaskars and the Tendulkars, history has been quite cruel to the second generation. And our next speaker, Dr. Anand Bang, has actually changed that narrative. Because he was asked to fill in the shoes of a very great couple, the Bangs, Abhay and Rani Bang. And that was obviously not going to be an easy task. But if you see what he has done today, you might want to say he's not really a chip of the old block. He's the block himself. And we are very privileged that Anand has actually taken out time. He's a medical doctor by profession, but then he chose to take up public health, and then now he's a master's in public health. When you try to Google him, if any of you wish to, your phone battery may die, because there's so much stuff about him. There are names like John Hopkins University, Government of Maharashtra, all the stuff that comes up about him. But he's a very humble and down-to-earth guy. You don't even see him here sitting, you don't even know where he's sitting. All I can say is that he's currently the joint director of the search project in Gadchiroli. He's an advisor to the Chief Minister of India, of Maharashtra, and he's an advisor to the Tata Trust Healthcare Foundation. So, ladies and gentlemen, he's going to be our chief guest today to unveil the book on the Gadchiroli Chronicles. But Anand, if you're up for it, we'd love to hear some things about you. Please.
The journey began in 1998. 165 tribal representatives from the Dhanora Taluka of Gadchiroli, one of the worst affected by Naxalite violence in the country, they voted in the annual health assembly in Gadchiroli that back and joint pain is one of their 4 most important health priorities. They were very forward-looking. They knew that the global burden of disease in 2017 and in 22 will exactly say the same, that joint pain and back pain and neck pain is the #1 cause of global disability. How big is it? Gadchiroli, 40% of the people have to stop their work due to disability. #1. #2, every second person in any village at any point of time has back or joint pain. #3, in an average village of 400 adults, 24,000 work days are lost every year because of back and joint pain. #4, even in a remote and tribal district like Gadchiroli, the annual economic loss due to back and joint pain is up to 200 crore rupees per year. So, unquestionably, a major disability economic loss. The problem with the back and joint pain, though, was, fortunately, or rather unfortunately, no one dies because of back pain and neck pain. And unless you die, cynically, that doesn't become a national health program. So despite this being the most important issue for the people, there was no national health priority or program ever. And that's how the story began. When I look back over 27 years of journey, 9 lessons come to me. Number 1 is actually a story of my grandfather, which again Dr. Bhojraj subsequently exemplified. My grandfather was a freedom fighter, close associate of Mahatma Gandhi. He was appointed by the Mahatma as a professor in a college in Wardha district, teaching national syllabus to the people. National means syllabus designed by Indians for Indians. 1942, Chale Jao, went to jail, came out in 1945, and then went to meet Mahatma Gandhi. He was given Ohio State University PhD in Economics scholarship, and he wanted to take the blessings of Gandhiji. So he went to Sevagram Ashram. Gandhiji knew him, so appointment was given. Gandhiji's appointment time used to be 2 minutes, 3 minutes. So every second was precious. My grandfather entered the hut of Mahatma Gandhi, Bapu Kuti. Gandhiji was sitting on the floor, mud covered, looked up. Bataiye Professor Bang, kaise aana kiya? Grandfather shared that this is the thing, now I want to learn further economics, I will come back and contribute to the economic glory of India soon to be independent. The freedom was on the horizon. Gandhiji looked at him for a few seconds and then uttered a single sentence. अर्थशास्त्र सीखना है तो अमेरिका की जगह भारत के देहातों में जाओ. That's it. And then again the old man continued his life. My grandfather came out in front of Bapu Kuti, tore away his visa, scholarship papers, and straight away started living like an agrarian farmer of Vidarbha. What is the till the age of 95, he continued as a Gandhian. We used to ask him, what was the power, what was the message of the old man that you changed your life with just one single sentence? My grandfather said, Gandhiji was telling me, go where the problems are and not where you end up becoming a problem. Dr. Bhojraj exactly did that. He thankfully came out of Lilavati, first crossed Mithi, then crossed Vainganga and came to Gadchiroli. So go where the problems are. Second, in Indian philosophy, there is a fundamental question. Koham, who am I? Existential question. All of us, hopefully, some point of time in our life face that. But that question sometimes can be a selfish question. The better question is, whose am I? For whom do I exist? What is the purpose of my existence? And that requires a tremendous restlessness and trying to find the purpose in life. J. Krishnamurti said, if a trooper is marching asynchronously, probably he is listening to a different tune. Dr. Bhojraj and his colleagues not only listened to that different tune in Bombay, but probably create their own music and symphony in the midst of concrete. And that restlessness is, I think, the second lesson that brought him to Gadchiroli. Mind you, at the peak of 2004, left-wing insurgency in India, Gadchiroli effectively was a liberated zone. It required some courage. So I think the second lesson was the drive to find the purpose of life. The third, Dr. Taylor, the dawn of public health, and who wrote the Alma Ata Declaration of Health for All, used to say that public health professionals are like children with a key in their hand trying to find the lock. Ideally, that applies to all the professionals. Everybody has a fancy solution. We are just trying to find the appropriate problem. Should begin exactly the other way around. First find the problem and then design the solution. Doctors, the challenge can be, we are so engrossed in our medical care that it reminds us of what the poet Brecht said. When the entire Eastern Europe was under the Iron Curtain of Stalin, Brecht wrote that this government is extremely good and just and efficient. It is the people who are idiots. We must get the people changed. Doctors can be similar. Our medical care is amazing. The patients are stupid. Let us get the patients changed. Our insistence on pathies can be pathetic. Dr. Bhojraj and TSF is exactly the opposite. They have that tremendous humility and self-confidence to relearn their modern medicine and go to people and find the true problem and begin with that. Number 4 is a story again of failure from Gadchiroli, which we learned. 1987, a young girl came to my father who was sitting in his OPD. This young girl had distended abdomen. She was pale, very anemic. My father got the blood tested. The blood showed sickle-shaped red blood cells. Classical case of sickle cell. So a district-wide sample survey was done. Everybody in research was very excited. We have found a new disease in Gadchiroli, in tribal, etc., etc., and found that 12% of the population has sickle gene. Findings published. Health Minister of Maharashtra came down to Gadchiroli, patted our back, and said that Maharashtra government will now set up a special center for tribal health. We are of course very happy. What a victory! 1 month after news came out, certainly the tribal healthcare center was set up, but in Pune. Tribal in Gadchiroli, sickle cell in Gadchiroli, center in Pune. So we went back to people that this is gross injustice and something must be done. The tribal people flatly refused. They said, "Doctor, you are young, you came like a guest to our village, asked for a drop of blood. Who says no to a guest? So we give you a drop of blood. Did we ever ask you to work on sickle cell? Did we ever complain of sickle cell? No. This disease is yours, that center is yours, that headache is yours. Don't trouble us." Exactly same could have happened with Dr. Bhojraj. Surgeons, like the eye of the tiger, constantly find the operation theatre where spine surgeries could have been done. Now Dr. Bhojraj and his team never did that. They never imposed any solution. So they always realized that their work must address the needs of the community in Gadchiroli and not the community that they work with in Bombay. So that is the 4th lesson. 5th is, then how do you find the problem? By listening to people. Now, doctors again are not renowned for listening. There is God and there are doctors. In between heaven and earth are room. Because listening requires tremendous attributes. Ronald Ross, a British malariologist, he was working in JJ here by the way, and that building must be reserved for his work there. He was working on malaria and he had an inkling that mosquito and malaria, there is some relationship. What is it? So he went back to London, and on the footpaths of London he was walking with his guru Patrick Manson, the father of tropical medicine. And Ronald Ross was sharing that, Dr. Manson, there must be some association, I'm unable to figure it out. Patrick Manson said, "My dear son, if you want to do research on mosquitoes, learn to think like a mosquito." That is what exactly Dr. Bhojraj and his team did. They came to Gadchiroli with humility. I remember the day when Dr. Bhojraj and Raghu and Samir and Gaurish were sitting in a village on a wooden log in the OPD of a quack doctor. And that quack doctor was telling Dr. Bhojraj and all these as how spine care should be managed in Gadchiroli. Without any ears at all. So humility. Second is vulnerability. Making oneself completely vulnerable. How vulnerable? I remember 1 o'clock in the night, Dr. Bhojraj in a remote tribal village, 70 patients waiting outside. Dr. Bhojraj is seeing patient after patient. There is a charpai in the Gram Panchayat building, and patient enters inside. He is lying on that charpai. Dr. Bhojraj is examining the patient. and then suddenly a cobra enters that room. Moment that cobra enters, that patient with serious back pain who had entered like this suddenly jumps up, runs out of that room, and he locks the room from outside. So now it is Dr. Bhojraj who has to sit on a table and the cobra is slithering downwards. This vulnerability to live with a cobra in the villages of Gadchiroli. Incredible commitment. He was on the way to Gadchiroli. Vilaswal Deshmukh, then Chief Minister of Maharashtra, calls him. Dr. Bhojraj, I have neck pain. Can you come and see me? Dr. Bhojraj tells him, I am going to Gadchiroli. Wait for 7 days. I will come back after that and see you. He took his flight to Gadchiroli. Vilaswal Deshmukh waited for 7 days. So that commitment to the people of Gadchiroli. And finally, anyone who has been at the receiving end of his morning burst of 7 WhatsApp messages and 2 voice messages would know the lifelong pursuit and curiosity. That, I think, is the 5th message. 6th, the constant faith on knowledge creation and science. India is unfortunately the national pastime is peddling of unscientific nonsense. Thankfully, Dr. Bhojraj, we found a colleague who believes in our dictum. One accurate measurement is infinitely superior to 1,000 intelligent opinions. And especially in social sector, we are so full of opinions on every damn thing in heaven and earth. Our motto has been to create a community laboratory of 300 villages. And our dictum is every pain counts. So count every pain and account for every disease. And with that, never be a fossil. Again, which so many social organizations are. Constantly look at our data, create new solution, don't be a fossil, identify new problem. And so with Gaurish, we have identified now neuro-rehabilitation as the next challenge. Stroke is the #1 cause of adult death in rural and tribal Gadchiroli. India has undergone the epidemiological transition. Many die, but more than that, people survive. What to do with them? Can we at least bring back them to the level of activities of daily living? So finding new challenges, creating solutions through constantly being adherent to truth and data is the 6th lesson. 7th is always develop a model which is sustainable. Test of problem solving is whether through solving the problem, the person whose problem is being solved, is he becoming empowered? That requires transfer of the power of knowledge and the knowledge of finances and the knowledge of skill. That also requires security at mind, that I am not the sun. Everything does not revolve around me, let me transfer it to them. So the model where community health workers to be trained in providing basic care in the villages and identifying their flag. Or creating a cadre of physiotherapy assistant, where physiotherapeutic can be transferred. How a simple BAMS medical officer can be trained in orthopedic screening and finding red flags. All this transfer is constantly because of that. Second, the relentless focus on prevention. Again, doctors love curative care. Why? Very simple. Dr. D.A. Henderson, the father of the global smallpox eradication program, and humanity achieving the eradication of smallpox is one of the greatest victory of mankind ever. Dr. D.A. Henderson was leader of that and subsequently Dean of Johns Hopkins. In one class, he said, "No one has ever thanked me for not having smallpox." That is both the unfortunate tragedy of public health and prevention. If you treat a patient through angioplasty or bypass surgery, lifelong debt. It should prevent by trying to just change lifestyle, not treat. So again, that requires this focus, that power shift has to happen through empowering a person through prevention. And finally, for 400 years, medicine has been caught in the Cartesian duality, that mind and body are different. I think so, I am. And when you completely disconnect two things, then you don't look at an individual as a holistic. There is a machine body and then there is a mind. Dr. Bhojraj and his team's focus in this entire spine care has been no. We understand that mind and body work together. So when we try to solve a problem, we want to get over this Cartesian duality and create a sustainable model of spine and joint care. Eighth lesson is how a social sector partnership should work. 24 years we are with Dr. Bhojraj, TSF, Rehab Institute, Dr. Jain, everybody. Social sector organization partnership should have 4 criteria: values, goals, roles, and processes in that hierarchy. Most important are values, then goals, then roles, then processes. Unfortunately, many partnerships begin exactly with the other way around, only with the processes which actually are the least important. So for us in Gadchiroli and in Search, this is a beautiful example where the values are completely aligned in every single way. And that's why for more than 20 years, this beautiful relationship has survived. Ninth is looking at TSF as a social sector organization. And I ask forgiveness for many dermatologists in the room, but the thing is, social work cannot be dermatology. Forever treating a patient. Social sector organization has 5 key purposes. 1, be moral torchlight for the society and set values. Number 2, provide services to the vulnerable. Number 3, creation of knowledge and new solutions. Number 4, be a channel for expressing the desire for others to contribute. And number 5, be a whistleblower. All of this leading ultimately to a changed human being. And this is what exactly the TSF is doing. That is the 9th lesson. What is the future? It will be the exciting possibilities which of course we will not share here, but rather extend a standing invitation to all of you to Gadchiroli. Our vision and mission remains the same. How far a claudicating elderly can walk with only the support of a stick, spine and joint care must be made available within that distance. And let me end again with a story. I began with Gandhi, so another story of Mahatma Gandhi. 1947 Kolkata, India partitioned, bloodshed everywhere. Western border, Punjab, tremendous bloodbath. In Kolkata, Gandhiji's fast and Kolkata is peaceful. Mountbatten said that my army of 50,000 cannot maintain peace on the western border. One-man army is maintaining peace on the eastern border. Young man goes to meet Mahatma Gandhi, very sad, grieved that why the bloodshed, violence everywhere. And he says, what should I do when faced with a problem in life? What should be my path? Gandhiji said, the answer is very simple. I shall give you a talisman, Jadoo ka Taveej. When faced with a dilemma as to what your next step should be, bring before your eyes the most wretched and vulnerable human being you ever saw and ask yourself whether the step you contemplate will help him, will it empower him. For us, again, that claudicating elderly, that woman who is trying to sleep after 10 hours of paddy cultivation, and that patient of stroke, our talisman. Hope you find yours. Thank you.
May I invite the founder of the Spine Foundation, Dr. Bhojraj, on stage, because this is the pinnacle of this morning. We're going to actually, you realize that Gadchiroli is full of stories, and a lot of these stories are depicted in this monogram, if I may. It's the Gadchiroli Chronicles that's being unveiled today. May I invite our President Dr. Raghu Verma and our founder Dr. Shekhar Bhojraj to give our chief guest Dr. Anand Bang a hand in inaugurating this Chronicles of Gadchiroli. There are givers and there are getters, right? I'm going to first call the getters.
This meeting was very important because we decided to acknowledge and honor the center heads of all the centers we have. As you can see, we are presently having more than 30 centers. So we specially invited the hosts or the caretakers of these centers, whom actually they had not met amongst themselves and all the trustees because we go for different camps. So we were very fortunate that at least 50-60% of them agreed to come, and we would like to acknowledge them by giving them a memento, a copy of as well as a copy of the Gadchiroli Chronicles.
Good afternoon, everyone. On behalf of the Spine Foundation, it's my proud privilege to deliver the vote of thanks. First and foremost, our heartfelt gratitude to Dr. Anand Bang, not only for launching the Gadchiroli Chronicles, but sharing those wonderful stories with us. My sincere thanks to our speakers, Drs. Raghu Verma, Gaurish Tinkre, Denny John, and Mrs. Archana Bhojraj for giving us valuable insights that remind us where we stand, what we have achieved, and where we must go. Thank you. A very special acknowledgement to our colleagues from the TSF RSCCs, the centers all across the country. Your tireless service in the remote part is what is the true strength of the foundation. Thank you very much. I would also like to thank our anesthesia team, rehab specialists, research collaborators, Rotary partners, many volunteers, SFFG doctors, and TSF admin and support staff. Your work behind the scenes is what makes our dreams possible. Our gratitude also extends to our media and marketing partners, Pep Media, and our publishing partners, the Brand Book Company. Thank you for bringing today's event to life so beautifully. Thank you. And finally, to our donors and well-wishers, your faith and generosity is what keeps our journey moving forward. Thank you so much. Most importantly, thank you one and all who have spent their Sunday mornings with us. Your presence here is a powerful encouragement for us to keep going. With that, I invite all of you to join us for refreshments. We've kept some Gadchiroli Chronicles outside if you guys want to go through it. And please, if someone is interested, you could just drop down your details and we'll mail them to you. Thank you very much.